Hi everybody, it's Cherry. Hey, I wanted to take just a quick second and talk to you briefly about the OPQRST sample history. If you're moving from trauma into medical assessments, then this is going to be something new. It's a super valuable tool, guys. It's the main difference between our medical and trauma assessments. Now, although trauma's cool, you got blood and guts and all that good stuff, so it's easy to see traumatic injuries most of the time. And we can always use our trauma, our mechanism of injury, to kind of figure out where our injury is and how bad our injury might be. We don't have that luxury with medical patients. And I love medical patients because honestly, this is where you have to use your smarts. This separates the men from the boys, so to speak. And we've got to use our critical thinking skills and our history taking skills to figure out what's wrong with our medical patients. When we have pain and trauma, we know what causes it. When we have pain in our medical patients, that pain is trying to tell us something, and we have to figure out what that is that it's trying to tell us. So our history taking is our biggest, best tool. Learn how to use it. Okay? Now, it is going to be used to assess pain or discomfort in a patient. So when you arrive, if your patient just feels weak or just feels yucky, like they have the flu, then this maybe isn't going to apply. But if your pain has some discomfort, which can be difficulty breathing, that's a very uncomfortable feeling, so we can use it for difficulty breathing, then the OPQRST is going to give you lots of good information. Okay? So the first part of OPQRST is obviously O, that's the onset. So there's two things I want to know with this. What were you doing when it started? And when did it start? Okay? And that's fairly easy, but like in the case of chest pain, if my patient's working really hard when the chest pain came on, then that has me concerned, but not as concerned as my patient who was sitting in the recliner reading a newspaper when the chest pain started. Because one of them, the heart's under a lot more stress and working harder, so it's maybe realistic that that part of the exertion and the oxygen demand is causing the chest pain, whereas the other one, that's not the case. So those are good questions to ask and find out what were they doing, how long were they doing it, etc., etc. Now, the when did this start? I want to know in this particular instance right here, when did it start? When we get down to T, we're going to ask that same question, but in a different format. Okay, so P is provocation, and sometimes you'll hear it say, hear people say provocation or palliation. Those are opposites, meaning provocation, what makes it worse? What provokes this pain? What causes it to get worse, this uncomfortableness? Palliation is what makes it feel better. So my question to my patient, I don't want to ask in these big fancy words that my patient can't understand. They're already stressed. They already have anxiety. They have enough. They've called an ambulance. So very, very, in a nutshell, I want to say, what can you do to make this pain better, or what could you do that makes this pain or uncomfortableness worse? Oftentimes, in the case of congestive heart failure, people that have fluid in their lungs, they're going to tell you that laying down flat or laying in bed makes it really bad. When I hear that, bingo, I'm starting to think congestive heart failure, and already I'm starting to develop a treatment plan in my head. I want to listen to lung sounds. If they have wet lung sounds, I want to check a blood pressure, and I might be considering CPAP on this patient just because of that question. So it gets me started down a path. Not to become tunnel vision, but it gets me started. Quality. Now this one we have to be really, really careful. Remember, we're asking open-ended questions. Questions that they have to answer using their words, not yes or no, and not shaking their head. So this question I always ask in this way. In your own words, describe the pain. Because sometimes you see people say, well, would you say this is a sharp pain or a dull pain? Well, what if it's a pressure? And it's not really a pain, it's just this intense pressure. But I've said, is it sharp or dull? Well, they feel like they have to pick one of those. So they're going to pick dull because that's the closest thing. But by asking it that way, I have totally missed the boat. They're now not going to tell me that this feels like a pressure because I haven't given them that opportunity. So I ask them, in your own words, describe this pain to me. Now, in my shortness of breath patients, I could say, in your own words, describe how does your breath feel difficult. Is it difficult to inhale, difficult to exhale? Do you feel like you're not getting enough in? What about breathing is difficult? Okay. So that one has to be really carefully worded because you want to get the most descriptive words out of them that you can. So make sure you're not asking a leading question there. Now, radiation. This one's kind of cool because people say, well, does your pain radiate anywhere? Well, most of the time your patients look back at you and go, what? So if my patient has told me they have chest pain, then the question I'm going to ask them is, does this pain go any place else? I spelled that wrong. Else other than your chest? Okay. And then I always follow it up with, using your finger, draw a circle around where your pain is located. And sometimes what you find out is they're like, well, it's in my chest, but it kind of goes up my neck here. And that changes things. So I want to know that full quality. So by asking both of those, I feel like I get better information that I wouldn't get before. Okay. Now, severity. I have to laugh at this one because this is on a scale of 0 to 10. I use 0 to 10. Now, your textbook may say on a scale of 1 to 10. I don't think that is the best way we can ask this question. Because if I say on a scale of 1 to 10, what if their pain is 0? And I'm asking them on a scale of 1 to 10. They don't have the option to say their pain is 0. So I want to start on a scale of 0 to 10. That way, if I give the nitro and the pain goes away, without changing my scale, I can know that. Okay, so on a scale of 0 to 10, 10 being the worst pain you can imagine, rate your pain. Now, I have to tell you, I'm going to confess a little. I used to think that when patients would tell me, oh yeah, it's probably at least a 9, and they're not even grimacing on their face, inside my head, I'm going, oh my goodness, what a pansy, okay? Because I grew up in a family where, unless you've lost an appendage or you're bleeding to the point you're going to bleed to death, you probably shouldn't complain about it. And so, this isn't what this is about. This isn't about measuring their durability or measuring their pain resistance. This is about measuring their pain, period. We're going to use their ruler to do this, and we're consistently going to use their ruler. So it doesn't matter what my ruler is. If I had that kind of pain and I was rated at a 3, but they're having this kind of pain and they're rating it at a 10, then we're going to use their ruler. I don't really care if they're a pansy or not. I want to be able to measure, is this pain getting better or worse? And that's my entire focus on this. So I always ask them to rate the pain 0 to 10. And I always tell them, we're going to continue to ask you this question over and over and over. And once you get to the ER, they'll continue with that same question. So please don't get frustrated if we keep asking. We're just trying to measure if the pain's getting better or worse. And that way I'm preparing them and they don't think we're a bunch of idiots. And they also know why we keep asking the question. Okay. So the last one on this is time. And remember I said at the beginning when we talked about onset? So here I'm going to say, when did this pain or discomfort first begin? So at the beginning, when we talked about onset, when did this episode begin? But I want to look at the big picture here. So if they're having chest pain and it began 20 minutes ago, but they've been having some chest pain on and off for 2 days, then I want to know that. So I want to know, when did it begin? But big picture wise, have you had this pain before? Is this the first time it's happened, or has there been episodes of this before? So I can get that full picture. Okay, now that's OPQRST in 10 minutes. I'm going to be done by 11 minutes. I hope it helps for your medical patients. It's to give you a bigger, better picture of what's going on inside them. Now I'm going to do another video about the sample history that's going to kind of dovetail to this and give you a really good medical history. So take good care of your medical patients. Rock on, guys.